Good morning, I'm Kritika Tyagi and I'm presenting my seminar on prognosis of OCD. My moderator is Dr. Aditi Bhatia. First of all, what is OCD? The full form of OCD is obsessive compulsive disorder. Obsessive compulsive disorder is represented by a diverse group of symptoms that includes intrusive thoughts, rituals, preoccupations, compulsions. What is obsession? An obsession is a recurrent and intrusive thought, feeling, idea, or sensation. And what is compulsion? A compulsion is a conscious, standardized, recurrent behavior such as counting, checking, or avoiding. A patient with OCD realizes the irrationality of the obsession and experiences both the obsession and the compulsion as ego-dystonic, that is, unwanted behavior. These recurrent obsessions and compulsions cause severe distress to the person. These are time consuming. These interfere significantly with person's normal routine, occupational functioning, usual social activities, and relationships. A patient with OCD may have obsession, compulsion, or both. The clinical features and diagnostic criteria. First, the presence of obsession, compulsion, or both is necessary. Obsessions are recurrent and persistent thoughts, as I told earlier. Urges or images experienced at some time during the disturbance as intrusive and unwanted. The individual attempts to ignore or suppress such thoughts, urges, or images, or to neutralize them with some other thought or action. That is called by performing a compulsion. And compulsions are defined by repetitive behavior or mental acts that the individual feels driven to perform in response to an obsession. The behaviors or mental acts are aimed at preventing or reducing anxiety or distress, or preventing some dreaded event or situation. The second is the obsession or compulsion are time consuming or cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. Third is the obsessive compulsive symptoms are not attributable to the physiological effects of a substance or another medical condition. Fourth is the disturbance is not better explained by the symptoms of another disorder. Now, these are examples of common repetitive behaviors people with OCD exhibit. These are repetitive hand washing, bathing or cleaning, obsessive tapping, placing objects in a specific order, counting, or repeating words or actions. Now we come to prognosis of OCD. The course of OCD is generally chronic, and in the absence of interventions, symptoms may persist for decades. More than half of the OCD patients have sudden onset of symptoms. The onset of symptoms for 50 to 70% patients occur after a stressful event such as a pregnancy, so the sexual problem, or death of a relative. About 20 to 30% of patients have significant improvement in their symptoms. 40 to 50% have moderate improvement, and the remaining 20 to 40% patients either remain ill or their symptoms worsen. About one-third patients have major depressive disorder, and suicide is a risk for all the patients with OCD. Prognostic factors. The recent outcome studies included treated patients. So these factors are considered to be predictors of treatment response. The three main factors are socio-demographic variables, illness characteristics, and comorbid disorders. Most consistent factors associated with outcome of OCD in individual studies are age at onset, gender, baseline illness severity and duration, and early treatment response. Some inconsistent factors are symptom dimensions, disorders such as depression, developmental disorders such as tic disorder, personality disorder, schizotypal disorder, course of illness, family's involvement and reaction towards the patient with OCD. Poor prognosis is indicated by an adolescent or later onset of illness yielding to compulsions rather than resisting, bizarre compulsions, the need for hospitalization, delusional beliefs, coexisting major depressive disorder, presence of overvalued ideas, presence of a personality disorder, higher accommodation, and higher expressed emotions. And good prognosis is indicated by onset in early onset in early or middle childhood, low severity and short duration of illness, early recognition, early intensive treatment, continuation of treatment for long term, combined treatment with SRIs and cognitive behavioral therapy, good social and occupational adjustments, presence of precipitating events, episodic nature of symptoms. Neurobiological prognostic factors. Structural neuroimaging showed anterior cingulate cortex volumes to predict short-term and long-term responses to SRIs and cingulotomy. Response to fluoxetine and CBT over a 12-week trial is predicted by neuropsychological performance at baseline on tests for selective attention, verbal memory, cognitive flexibility. Response to a 12-week treatment with paroxetine is predicted by a functional neuroimaging study that shows elevated activity in the right quadrant. Discontinuation after prolonged treatment has lower relapse rate. The compliance of patient plays a key role in a long-term outcome. Thus, patients should be encouraged to remain hopeful and to try a range of different evidence-based interventions over time. These are my references. And thank you.
Good morning, everyone. I, Kirtika Putra, I am here to present on my topic Prognosis of Unipolar Disorder under the guidance of Dr. Rishani. Here comes the definition. Based on the DSM-5, it is a period of at least 2 weeks when a person experienced a depressed mood or loss of interest or pleasure in daily activities and had a majority of specified symptoms such as problems with the sleep, eating, energy, concentration, and self-worth. What are the 7 most common causes of the depression? This could be the drugs, genetics and the biology, physical health problems, traumatic events, stress, poor nutrition, and brain chemical imbalance. The main symptoms includes low depressed mood, loss of interest, joylessness, lack of energy. Additional symptoms includes loss of appetite, sleep disorders, suicidal thoughts and the acts, negative perspective for the future and the feeling of the guilt and worthlessness,